Excellencies, ladies and gentlemen, welcome. Welcome to this wonderful building, the Global Health Campus, where today our partner organization, FIND, is hosting this event. If you're not familiar with FIND, you will very shortly be knowing a lot about it. Welcome to the French-speaking Forum for Digital Governance and AI. This forum is going to bring together, between now and Sunday lunchtime, experts in digital governance and AI from the entire French-speaking area. And this is an important event because we are between the adoption of the Global Digital Pact last September and the decisions that will be taken by the United Nations General Assembly on important topics, the AI dialogue, but also the architecture of digital and AI governance. Up until now, this governance had been organized on the basis of the Global Summit for Information held in Geneva and in Tunis. And this is what laid the foundation of the multi-stakeholder governance system based obviously on governments, but also the technical community, civil society, the industry, the academic world too, and all of these partners together worked on the governance for Internet, the last edition of which was held 2 weeks ago in Oslo. And we are right at the heart of this transition. This is important because everything is moving very quickly. The situation is evolving at very high speed. We need to be able to identify the assets, the advantages, but also the risks that we face. And that is why we truly want to be as inclusive as possible and discuss the topic and have an exchange on it. Now, we felt that we needed to have a dialogue, not necessarily on governance, which we'll be dealing with tomorrow and the day after, but this afternoon on a decisive application of artificial intelligence of health. We know what being able to move towards a global health system that is entirely inclusive, that leaves no one behind, would represent, especially in financial terms. We are all convinced that IT and AI can contribute to accelerating this model. And this is precisely what we will be working on today. This is what the many panelists who have and will be joining us will be covering. Now, when we speak of AI and healthcare, many obviously think of patient data, Is it secure? What is it used for? These questions are important questions. They are questions related to ethics and governance, and they'll obviously be dealt with during the forum that'll bring us together tomorrow and the day after. But it is also important that we know how health systems can use AI to guarantee access to care by all. That is, access to diagnostics, access to treatments, access to reliable vaccines, and always in a safe and affordable manner. How can governments use AI to defeat disease? How can we organize surveillance and detection for epidemics? In the case of diagnostics, can we, for example, use AI in a reliable manner to read X-rays of the lungs? For predictions, how could we, for example, anticipate amputations related to diabetes and avoid them? For planning, how can we use AI to optimize the location of services and the distribution of healthcare professionals? This is something that I personally discovered when I became interested in healthcare as developed in the multilateral context. Healthcare is logistics, and how will AI prepare us for this kind of challenge? We'll speak of the digital divide, the diagnostic divide, the validation of AI tools. We'll speak of transparency, and in concrete terms, we'll speak of what it takes to deploy AI systems while creating local ownership and ensuring the sustainability of these solutions now, not only for the years to come, but also in the medium and the long term. I would like to warmly thank the partners of FIND who established and set up the workshops that bring us together today. I also thank my team, of course, at the OIF, who worked on the program for this forum. You have information on the forum and on the various speakers for the days to come online. And I would now like to give the floor to Dr. Ifedayo Adetifa, who is CEO and Chief Transformation Officer of FIND, to make his opening statement for this afternoon. Dear Director. Thank you so much.
Good afternoon and very warm welcome to our participants here, you in the room and those online who have committed time to attending this session at this set of meetings organized by the OIF and FIND with support from the Patrick J. McGovern Foundation. Obviously, there will be no meeting without you guys, so we appreciate you committing your Friday afternoon for this purpose. As the Honorable His Excellency has said, the role of AI in transforming equity, especially in diagnostics as a subject, is an important one, and certainly meetings like this in the context of what's going on in the global health space regarding AI and beyond the health sector means that this is, of course, also urgent to make sure that the health bit is not left out. But there will be those, including, I think in the course of organizing this meeting, we had colleagues in the building who actually wondered why FIND was hosting an AI meeting. And that's, we're in the Global Health Campus where everybody is supposed to be a convert and should understand what the issues are. So it means we can't take it for granted what the applications of AI are, and I think it's important that I touch on that. So We are in the Global Health Campus, and of course, there are various interpretations or definitions of what global health stands for. The one I like the best is, it's a field of study, research or practice, so covers everybody here, that places what a priority is placed on equity in health for everybody. So global health is essentially about equity in Maryland, in Oslo, in Abuja, in Cape Town, in Buenos Aires, or even in Rio de Janeiro. And the link between AI and health equity, which, as I say, is the aim for the main output for global health, lies in the opportunities that AI offers to reduce existing disparities in healthcare and the risks as well that it poses to worsen or exacerbate them if we are not intentional, or if we do not have discussions such as this to begin to proactively make sure that health and health equity is not left in the wake of the conversations, the decisions, and the advances that are being made in the AI field. We do not want a repeat of what we saw with many new and underutilized vaccines. Our colleagues in Gavi have a lot of work to do and have had significant impact over the years, because prior to Gavi and in about 2-3 decades ago, when some of the new vaccines came on board, for example, hepatitis B, which is everywhere now, it took almost 20 years for those vaccines to begin to be introduced for routine use in the more resource-constrained parts of the world. And we saw something similar with pneumococcal vaccines, but the distance between the licensure of the more recent or more popular human papilloma virus and routine introduction has been much shorter. And the case has been seen with other vaccines. So it is important that we begin, just like it was recognized at the time, to make sure that AI serves all of our aspirations for equity. So the next question that might be popping up now is, how can AI promote health equity? Well, there are a few domains. One, as His Excellency already referred to, early detection and diagnosis. AI can detect patterns in medical data that lead to earlier diagnosis of diseases like cancer, diabetes, or even heart disease. And whether the clinicians like me agree or not, in many situations, AI has actually been demonstrated to do better than human experts. The other is AI can help with improving access to care. We've got a healthcare worker shortage in terms of the number of healthcare workers, whether they're doctors, nurses, or midwives. The numbers you need per 100,000 of population poses a significant gap, especially in underserved and more rural parts of countries. We've got a challenge that AI can help bridge in terms of telemedicine, chatbots and apps that help with decision making, and can, of course, bring healthcare closer to people living in remote and underserved areas. AI can help healthcare systems optimize the use of resources, can help inform data-driven public health. Often countries and healthcare systems generate a lot of data. I mean, the focus usually is on sometimes there's no data or there's an issue with quality of data, but there's also underutilization of available data that is needed to inform policy, inform allocation of resources. And AI systems can help deal with that volume of data, identify patterns or trends that can then be used to prioritize need or even the needs of attention for vulnerable populations as well. And then, of course, it's personalized medicine. So the point that we are trying to convey is that without intentionality, without proactive actions, the march of AI can also worsen health inequities. And people may say, how is that possible? Well, there are a few ways. One is you can have biased algorithms. Okay, so if all of the information that's behind in teaching or getting AI to learn what to do is all informed by data from one part of the world. So say if there's a lot of data from Europe, from Switzerland, and very little from my village, then it means that the AI solutions for health are simply not going to work for my extended family far away in Africa and in my village. So we need AI to be trained on data that is fully representative of all racial, ethnic, and socioeconomic groups so that we have more accurate and of course less harm in terms of misdiagnosis and undertreatment. We already have a bit of that. I'm not sure how many people are familiar with the challenges with pulse oximetry, for example, and interpretation of oxygen saturation levels on, say, darker skin, okay? That's a typical example of what happens when a very useful diagnostic tool is not appropriately trained with all, or an inclusive approach wasn't taken to sort of programming it to do the essential job that it was required or was manufactured to do. There is the risk of worsening the digital divide. We've got colleagues from ITU. We know what the situation in many countries are in terms of internet access, digital literacy, or access to technology. So these are required for AI-powered healthcare tools. So in the discussions around, it's important that we discuss AI in this setting so that attention is also given to the infrastructure and gap that exists, and of course, even the human capital gap in terms of training and knowledge. AI can worsen health inequity by lack of representation. So if AI development teams are concentrated in one part of the world, then you also have an issue. So as part of this conversation, we hope that common action will be taken, or it will be identified. The pressing need to also make sure that the necessary human capital in terms of skills and knowledge are invested in to ensure that there's equity. There are privacy and surveillance concerns regarding AI in terms of health monitoring, and sometimes what typically happens is that they can disproportionately target vulnerable or marginalized groups, leading to then mistrust and reduced engagement with formal healthcare, which, as we witnessed during the acute phase of the COVID-19 pandemic, you can see what happens when populations do not trust the healthcare system or leaders. We also have to watch out for commercial interest. If all of the aspirations for AI or the use of AI is exclusively driven or predominantly driven by commercial interest, then that certainly will worsen health inequities. So it is important and in fact urgent to make sure that equity is not an afterthought, and equity cannot be an afterthought for people who work in global health and people who whose offices are in the global health campus and who come from countries where health is a priority. So today's dialogue is not just timely, it's essential to shape a future where innovation drives inclusion, drives equity, and not division. His Excellence referred to the diagnostics divide. So it would be remiss of me as CEO of FIND to not speak about diagnostics, because this is what we do. FIND has a vision of diagnosis for all. And what does that mean? It means that we're keen, along with other partners, along with countries and every relevant stakeholder, we are keen to ensure that everyone has access to high quality, affordable, and reliable diagnostics when and where they need them, whether it's for malaria, or it's for TB, or it's for HIV, or for vaccine preventable diseases. We want everybody to have diagnostics when and where they need them. Now, there is a diagnostics gap or a diagnosis gap, and this refers to already inequities in access to diagnostics, both in terms of not just the access, but in terms of even the quality and the accuracy. So, and this inequity or this diagnostic gap disproportionately affects people in rural and low-income communities, in low and middle-income countries or resource-constrained settings, as you might prefer, and indeed disproportionately affects marginalized populations. And marginalized populations exist everywhere, even in the capital cities of the biggest, richest countries in the world. Inequity in healthcare starts with inequity in diagnosis. Many people in the world do not have, you have symptoms, whether it's fever or headache, you manage to get to your healthcare facility, whether it's a primary healthcare center that is 5 kilometers away or your family practice. And what happens is that there are delays in terms of reaching an accurate diagnosis. And of course, that leads on to having delays in the timeliness of effective management. And without that, it means that suffering is prolonged. And of course, there's a higher risk of adverse outcomes. According to the Lancet Commission on Diagnostics, about less than half of the world's population have access to the diagnostic tools that they need. And this could be up to 80% if you go to primary care settings in many countries. Even here in Geneva, near the French border, I've had people complain from the French side, for example, because you're on the periphery, about access to healthcare, about access to diagnostics as well. Up to 1.1 million premature deaths in resource-constrained countries can be avoided annually by reducing the diagnostic gap for just 6 conditions. 3 of those conditions are covered by the Global Fund, who also are disputing. So TB, HIV, malaria. The others are non-communicable diseases, diabetes and hypertension, and there's hepatitis B and syphilis. So AI has a promise for diagnostics as well. It can help to do the following. 1, bringing scalable, low-cost diagnostic tools to communities. And we've heard about AI-powered smartphone apps. We've heard about imaging tools that can lead to prompt diagnosis just by using a camera or wearable sensors. We already have automated image interpretation. WHO, in the last couple of weeks, released a policy statement on the use of computer-aided diagnostic software for TB, using X-rays, and of course, FIND contributed significantly to that piece of work. There are AI tools now that are used for diabetic retinopathy screening. So basically, for those who know, diabetes is a multi-system disease. It's not just about amputations. It damages every end organ in the body, whether it's the kidneys. And one of such end organ targets for diabetes or poorly managed diabetes is the retina. So people can also go blind. And there are AI tools now that can reliably diagnose the retinal changes that suggest that diabetes is about to cause blindness and, of course, prompt quick intervention. We've talked about decision tools. Rwanda, I think we will maybe hear about that, but Rwanda and the UK use the Babylon Health app, which help with decision-making at primary care level. So as I prepare to conclude, I think it's important. AI is the sort of new sexy topic, for want of a better description. It's like various things. It's making its way into every conversation. There are talks about AI taking my job and taking your job. So maybe I might be out of work soon if that is true. But we have to separate the hype from the reality. AI is not going to solve all of the problems of the world. In fact, I think the lesson we've learned as a product development partnership, as Global Fund, and is that innovation alone is not going to solve any problems, all of the problems. There are pieces of domains of challenges and improvements that we can gain from innovation, but that's not all. Technology alone would not close the gap. So we need to talk about responsible AI. And we have already mentioned that responsible AI requires inclusive design if you're not going to do any harm. So you need local data, culturally and contextually appropriate tools. We need transparency in regulation, in validation, in monitoring. We need policies, again, that safeguard privacy, fairness, and accountability. And more importantly, no single entity can travel the distance alone. So we need multi-sector collaboration, public-private partnerships, academic industry collaborations, civil society and community engagement, multilateral and donor-led coalitions. So I close with a call for action. So as we move forward in today's discussions, I invite all of us represented here, policymakers, innovators, funders, researchers, and implementers, to look beyond the promise of AI and focus on what the real-life impact will be, or what we expect the real-life impact to be. Let us commit to designing AI solutions with the communities that we aim to serve, and not just for them. So I like a particular saying that you can't shave my head in my absence. So I need to be present, hopefully conscious and participating, and even telling you how I want my hair cut to be done. Yes, I am using the hair example because I'm growing an afro at the moment. So, but we need to design AI solutions, and just like every other health intervention, in conversations with the communities that they are meant to serve. We must also not only invest in technology, but also in data readiness, in local capacity and governance systems to ensure safe, ethical, and sustainable use. Above all, let's ensure that equity is not just a guiding principle, but a measurable outcome of everything that we do. I wish everyone and us all an engaging and action-oriented discussion, and would like to express Find's continued commitment to driving responsible AI innovations that serve the most underserved, as we work towards our vision of achieving diagnosis for all. Merci beaucoup. Shukran. Thank you very much. It was getting very hot here, so I tried to escape very quickly from. Yeah, but it's a pleasure to move us along in the program to the next activity, which is the first panel. So panel one is going to look at the topic from inequities to innovation. Can AI bridge the health gap in low and middle income countries? This panel is going to be moderated again by His Excellency, Mr. Henry Monsieur, who I will leave to introduce members of the panel. Thank you very much.
Là, oui. Alors, je vais inviter les panélistes.
Allow me to invite the panelists to join me up front. Ambassador, I see you reading your notes, but it's your turn, so please. Please come up on stage. There's a panel here composed of several experts, so please take a seat.
Ce panel comporte deux anomalies. La première,
there are two anomalies in this panel.
pas beaucoup de dames.
The first one is that there aren't many women
Et la seconde, il y a
on the panel,
docteur,
and
docteur, et
the second is that everyone's a doctor except for me.
commencer,
And so
en vous présentant
perhaps we could
rapidement
start
nos panélistes. Vous avez
by
tous
giving you the floor
un
to
nom
introduce
dossier
yourselves.
qui reprend
You
à la
all
fin
have
la
the
panel et qui vous donne
document on your
de chacun.
chair with the composition of the panel, the names of the panelists and their biographies.
Portera,
So
officiel que vous voyez inscrit là-bas, des inégalités à
This
l'innovation
discussion will be about
peut-elle
inequalities in innovation. Can AI
Docteur Dayo en a dit
reduce
un mot à l'instant.
the
Monsieur
inequalities, the gap
Son Excellence, le docteur Jean-Pierre Baptiste, ambassadeur
in
Tchad et par ailleurs
the health gap?
grand
So
praticien
our ambassador from
dans le
Chad
domaine
is
médical, puisque
very
le
experienced
docteur Baptiste
practitioner,
est
medical
médecin
practitioner. As
et a
you're
travaillé
a doctor,
un niveau de responsabilité important pour
pneumologist, you
l'Organisation mondiale
have
de la
carried
santé
out important
en
work
Afrique.
for the WHO in
À ma
Africa.
gauche,
To my
le
left,
docteur Michel
Dr.
Amala Sidibé,
Michel Amala
l'envoyé
Sidibé,
spécial
special
de l'Union
envoy
africaine pour
from
l'Agence
the
africaine des
African
médicaments,
Union
qui a
for
été
the
le
African
ministre de la Santé du
Medicines
pays,
Agency. You were
qui était aussi,
previously
comme
Minister
nous
of
en souvenons
Health
tous,
in your country,
directeur
Mali.
exécutif
You
de
will
ONU-SIDA,
all
à
remember
quelques encablures
Dr.
du lieu
Sidibé,
où
you
nous
because you
trouvons.
were the former UN Deputy Secretary General of
Le
UN
docteur
AIDS,
Michael Charles,
Executive Director,
qui
and
dirige
Michael
RBM, et
Charles,
que vous connaissez aussi, qui est chez lui, qui est dans sa maison.
RBM Director, and you're here
Nous
at
nous trouvons
home
au sein du campus pour la santé
because we're
globale.
here at the
Le
Global
docteur
Health
Clément
Campus. Dr. Clément
qui est conseiller
Lazarus,
en santé
advisor
internationale et
on
mondiale
international and
auprès
global
du
health
directeur général de la
to the
santé
Director
au sein
General
du
of Health at
ministère
the
de la
Ministry
prévention et de la santé
of
de la
Prevention
France.
and Health
Bienvenue,
of
docteur. Ça va être
France.
facile pour moi, il suffit que je dise docteur. Après,
So,
ils vont se demander à qui je m'adresse, mais
all I need to do is say, please, doctor,
précisément,
you have the floor, but then none of the doctors will know who I'm talking to. So, ambassador,
comme beaucoup de pays,
as you're also an ambassador, the floor will be yours as Chad faces healthcare inequalities between the rural and urban areas. There are many inequalities among different categories within the population. So, in your opinion, how can AI help? And as we were saying earlier on, AI can't do miracles. It's a technology. It's based on science. It's a rational tool that must be used in a thoughtful way. But how could this tool help us bridge this divide? What are the priorities that must be studied to ensure AI becomes a lever for equity and health? And this is a question that concerns Chad, but other countries as well. Could you give us your opinion based on your experience and based on the challenges you know of in different countries and regions? Could you talk about what AI requires in terms of infrastructure and human resources and talk about those challenges? And the other panelists might also talk about this. If I'm not mistaken, to take the floor, you need to press on the button on the device. So it's not a question you were asking, because the question was about a page long. So thank you very much for your invitation. I'm replacing the Minister of the Economy of Chad that had to excuse himself. He was unable to attend due to a calendar clash. And so I came here unprepared. So please understand that the Minister of the Digital Economy has already made a very important statement on the topic, especially during a meeting in Washington. at which he talked about the digital work that's being carried out in Chad to modernize the country. But very briefly, I would say the following. My country, Chad, is at the center of Africa. We are surrounded by conflict-ridden countries, Libya, Sudan, Central African Republic to the south, Niger. So it's the only country of the sub-region that has just completed its transition with the presidential elections that were recently organized and the recent senatorial elections. We are the only country of the sub-region that has managed to move out of the transition phase. And so we face a huge number of refugees following the war taking place in Sudan. Our country, led by our president, decided to leave its borders open to our Sudanese brothers. When I asked the president whether we shouldn't carry out some checks at the border, he answered very clearly. He said that if we face the same situation someday, we'll be very happy if our bordering countries leave their borders open too. So basically, all that to say that Chad left its borders open to refugees. We gave them some land. There are some Sudanese refugees that have been here for 10 years, some for 15 years. So we welcome these refugees in Chad for XYZ reasons. Basically, it's the same people on both sides of the border, the Ahwad on the Tamil on both sides, the Buran on both sides of the border too. And so they're the same people, and that's why there are a lot of difficulties separating the people and counting the number of displaced people, because basically they're just going to meet with family on the other side of the border. So it's very difficult for us to count the IDPs. There are over 2,500,000 Sudanese refugees in Chad at present. They used to be in a single camp, the Agre camp, on the border with Abéché, not far from Abéché. But now, as the fighting has been ongoing along the 1,300 kilometers of border between us and Sudan, other refugees beyond Adre, Tinea in the north of the country have come too, but they haven't been counted yet, and they have not been cared for yet by international cooperation. Our Minister for the Economy and Digital Development recently, in March 2025, went to a meeting in Washington. At that meeting, he defined the main digital objectives of Chad and outlined the government's plan to modernize the country. That summit was based on digital paths for all. We talked about communication, connectivity, internet equity, inclusive digital transformation. Chad participated in the meeting in order to demonstrate a commitment to that worldwide trend. So there's a project currently financed by the World Bank for Africa in this regard. The M300 aims at connecting 300 million Africans to give them access to electricity, internet, and education. Hope within the next 20 years. Chad is one of the countries that will benefit from this project, which is based on 5 main objectives to bolster our weaknesses. So strengthen existing infrastructure, better energy provision in rural zones, connections between Cameroon and other countries, modernization of energy productions and the electric network through intelligent network. So I think before talking about internet for all, we need to ensure everyone has access to electricity. We have problems electrifying the country for many reasons. And so together with our Indian partners and other partners, we are currently working on solar energy and introducing solar energy in Chad. Our main hospitals, including our main hospital in Gemina, will soon be powered in that way. One of our main hospitals, at which I worked for 22 years, will soon benefit from that kind of solar power, solar electricity, which will enable us to avoid any outages during operations, to ensure that all our technology works and that it doesn't face outages. And so we need to start by ensuring electricity for all. Access to internet in Chad is no longer luxury, it's a fundamental right for each and everyone in the country. This digital access has been enshrined as one of the fundamental rights together with food and water. And so Chad has benefited from a Starlink license. It has access to the 27 internet providers that participate in that plan. So our objective is to connect 13,000 schools and several universities in that way, and to create multimedia centers. Now back to AI in Chad. Well, our priorities are to work on our weaknesses, education, healthcare, or other. And as you well know, AI won't solve all our problems, but we are doing our utmost to ensure that we first and foremost ensure that we have a more stable situation in terms of electricity and connectivity, so that each and everyone in Chad, not only in the cities, but in rural areas too, because there's a great difference between the situation in the capital and in rural areas. We need to ensure that each and every health facility and center has human resources and this access, because I'd like to thank FIND, because diagnostics is one of our weaknesses, and thanks to FIND's support, I think we will make progress and find solutions. With regards to telemedicine, training and cybersecurity, well, we have worked with the Ministry of Health to create a national platform for telemedicine. As the former doyen to this project, because it's something I'm passionate about, I worked in this area for many years. I was for 5 years at the Ministry of Education. So I'd like to welcome all the ambassadors that are in the room. Some of the students have become ministers, director generals, and they are people we trained. That is very rewarding. It's the only reward, actually, that we've received. But I must say it's good for the ego, and it shows that our work was beneficial. And I'm going to finish here. Just one last thing. So we need to make internet accessible. There are 2 providers available in the country at present, and there'll soon be more. So I'd like to appeal to the Chadian youth. AI is not a myth, it's a tool. It's a tool that can help us transform agriculture, that can help us transform health, that can help us transform education, that we can use in order to breach, to fill the gap. So we need to believe in our country, and that applies not only to Chad, but to the whole of Africa, and work intelligently. We need to ensure we as Africans cooperate across borders. Guinean has to work in Chad, Malian in Cote d'Ivoire. It's by breaking down these barriers that we will guarantee that Africa is strong and independent. And sorry that I didn't speak that much about AI, but I think each and every one of us has their own opinion on the matter, but we are all making progress in this regard.
I think that you've reminded us of 2 very important things. First, that inequalities need to be fought at the root. There are still 2.6 billion people who are not connected. The representative of the ITU will be able in another panel to mention this fact, so that needs to be taken into account, as well as issues related to instability that you mentioned. But there are, on the other hand, many reasons to believe there is huge potential, and this is the potential that we need to be looking at. And with that, I will turn to Dr. Charles.
In many low and middle-income countries. From your perspective in rollback malaria, how could AI help national malaria programs improve prevention, diagnosis, and response, especially in hard-to-reach and under-resourced communities?
Great, thank you. Thank you very much, Your Excellency. At the beginning, you said there were a few anomalies where all medical doctors were male. The other anomaly is that I'll speak in English, not in French, so apologies for that. But really just to thank the organizers, FINDS, Dr. Adetifa, my brother, for really, putting this together and really ensuring that we speak about artificial intelligence. I don't think we can escape from it in terms of, the new way of doing things and the opportunities that AI brings to all of us. But let me just dwell on malaria and, the questions you've asked. Malaria still continues to, affect over 263 million people every year, or cases, and we have over 600,000 deaths on an annual basis. We've made progress up until about 2015, but since then, we've really seen a reduction in terms of the progress we've made. And it's really based on 4 things, and I'll link it to AI. The first one is around the climate, climate change, more water, more rains, malaria goes up. We have issues around conflict in many African countries. We have the drug resistance, and then we have financial or funding issues. Now, if we take the issue of climate and really see how the linkage with AI comes in, Because of artificial intelligence, we're able to predict a lot more in terms of weather patterns. And with weather patterns, then we can see where outbreaks will come and really then position ourselves to be able to distribute commodities ahead of time in terms of, where the upsurges will be. For example, recently we had more cases in Botswana, in Namibia, because of the upsurge of rains. With the upsurge of rains, there will be the breeding sites for mosquitoes, which is potholes, gutters, etc. Again, with AI, we can really see how satellite images can lead us to those breeding sites so that we can do more larviciding, which is really spraying those breeding sites so that the mosquitoes don't grow. So I think AI really gives us the opportunity to be able to predict, to be targeted, and to really ensure that this meager resources that we have is really put to good use. I think the second issue is around conflict, which again comes with, population movement. And if we look at hard to reach areas, remote communities, remote villages, we will see that with the use of AI, with the use of population, with the population movement, we can see that AI is able to predict again where there will be increased cases, where there will be stockouts, and where we would need to quickly, replenish the stocks. Rwanda does that very well in terms of using drones to be able to get commodities to hard to reach areas. We heard from Dr. Adetifa, and my experience from going to many communities is that you would see a woman walk 3-4 kilometers, 1 hour, 2 hours to a health facility with a child. And the worst thing you want as a medical doctor, as a nurse, is to have to attend to that woman and tell her, sorry, there's no diagnostic, there's no treatment, come back tomorrow. Tomorrow often is too late. So I think AI is again something that is helping us to be able to predict this stockouts to ensure that we're able to serve the community members as much as possible. Two other quick things. When it comes to resistance is really stopping us in terms of progressing in terms of the fight against malaria. So AI can also help us predict in terms of genome sequencing where there could be potential threats for resistance and which commodities should be deployed to which areas at a reduced cost. So I think collectively, AI is really doing a lot. And if we continue to embrace it, we will see resource optimization, we will see effectiveness, and we'll be able to save more lives. Use of AI, we need to do it responsibly. We need to do it with the communities, and we need to make sure that countries are really at the center of the use of AI. As the RBM partnership, we're really working with this in terms of our mandate of convening, or really looking for frameworks where we can reduce the burden of malaria. We have what we call the big push to end malaria, and innovation AI is really an integral part. And I continue to encourage everybody to embrace it in a manner that is useful for all of us. Thank you.
Thank you very much, Dr. Charles. This is absolutely clear and give good perspective. Je vais me tourner maintenant vers Michel Sidibé.
I now turn to Michel Sidibé, Minister, dear Michel. Minister one day, minister forever is what we tend to say, but you are known globally and in particular here in Geneva because you are a champion in terms of equity for access to treatment. And that is, in fact, still your job as special envoy on AI at the French Agency for Medicine. So how do you see the link between AI and inequality? Will AI increase these inequalities, or on the contrary, will AI be a tool to reduce them? Thank you, dear brother Henri, and thank you in particular to IDEO and to FIND for having organized this get-together, which, in my view, is perfectly timely and topical. The danger when we speak of tools is to speak of them in an isolated manner, as if AI were an instrument, a tool that suddenly turns up, that we use or not, and that we adopt or not. What I think is very important, at least something that strikes me, I've just come here from London, and I would like to say that it's the world in which we live. We need to take a moment to ask ourselves the question. I think that today we are truly at a turning point, and I insist on this. The world is going through seismic change with major divides, which mean that increasingly those who have more and more, and those who do not have are left by the wayside. I hate these things, and you know that perfectly well, but referring to the microphone. Anyway, I'm saying this because it is so important. It is not just a mere budgetary crisis or financial crisis that we're experiencing. We're experiencing an ethical crisis with a lack of trust between the citizens and their leaders. And this is reflected, unfortunately, on the equity crisis. And this is where I come to your question. Artificial intelligence. Well, I was in Nairobi some 2 weeks ago. I was in a meeting, and an absolutely brilliant young man, an engineer, explained something to me. I was trying to understand exactly what he was referring to, and he kept showing me something, saying, have a look at this picture. You can easily see whether it's skin cancer or not. And I naively asked him this question, this candid question, and I said, but what if it was black skin? And he looked at me very sweetly and very politely, and he said, I don't think I could answer you today. So what I'm trying to say is that we absolutely need, if we want to speak about ethics, we absolutely need for AI to be based on ethics. A continent that bears 25% of the burden of disease and only 25% of health agents needs to be placed at the heart of that research. There needs to be ownership by communities. We've mentioned this. And in my view, I think we need to reach a situation in which those competencies can be transferred and be owned by the people. And then there is regulation, whether we like it or not. The algorithms need to be tested. There needs to be a regulatory framework at continental, at African level that enables us to say, well, this AI that we're trying to adopt currently meets our needs and can be used by our doctors, our experts, and our people who are at the margins of society. I think those are the fundamental questions. Ownership and, as His Excellency said, the link with all support technologies, because AI, you mustn't be misled. If there is no cloud that works correctly, if there is no data system, my young brother will probably speak about this in more detail, but if you don't have a cloud with proper data storage, if you don't have sovereignty in terms of access to those structures, well, then you'll have a tool that you can use, but you won't have a strategic vision that will enable you to move towards greater equity. And I think I'll stop there. Well, I think once again, those are words of great wisdom that help us a lot. I now turn to Dr. Lazarus. On the basis of your own experience, and we've spoken at length about Africa until now, but we could also look at matters that are related to France, our country. Have you managed on the basis of the work that you've carried out on inequalities linked to gender, geography, or the social economic status? Have you used or seen diagnostic tools based on AI that were used effectively to reduce inequalities? Or have you, on the contrary, seen situations where these tools could possibly enhance these inequalities? Well, thank you so much, and thank you, FIND, OIF, and Patrick Govan Foundation for having allowed for this event to be organized. Well, you said it was timely and topical. Now, you have been talking about digital and AI governance and AI at service of health. If you speak about it being at service of health, that means it doesn't necessarily happen naturally. There is a certain amount of complexity to the algorithms that are used, which create new issues, situations for our health systems, challenges and opportunities. Opportunities because it enables us to do new things, and each of you has provided us with some examples, and I'll give you more in a few moments. Risks and challenges because things change very quickly. It can disrupt our health systems. It can use up resources because all of this is extremely expensive, and the money used in AI and in these systems is not used in the health systems. And so we need to ensure that we have people keeping an eye on the use of money, making sure that it's used properly, and challenges because we run the risk of excluding some populations. There is no magic wand on AI, and we need to reason with AI as we do for other health-related matters. That's the first thing. My second comment, and this has to do with the title of our panel. The question was asked about low and middle income countries. Well, here I'd like to reassure everyone, in case you were doubting, in the room, health inequality issues, we experience them in France, as is the case everywhere in the world. We have inequalities related to gender. They're often aggravated by inequality related to the socioeconomic status or cultural matters. And they were all enhanced by the COVID pandemic, and not all indicators have returned to where they were before the pandemic. And so in France, we ask ourselves the same questions as we do elsewhere. I think these are universal issues, and that's why forums such as this one are organized. Now, a few examples. In France, we have a project called France Imagerie Territoire. It is a network that brings together over 500 radiologists, 85 X-ray centers throughout France, some in the major centers, others spread about. They contribute their resources to use AI to strengthen medical imagery, be it in France or in France's territories elsewhere. To give you an idea of volume, in 2024, this network carried out over 1 million examinations based on AI. So this is a quantitative jump that's significant. It allowed for prioritization of urgent cases. It allowed for early diagnostics. It allowed for swifter care for patients. And all of this was set up with the idea of never replacing the health expert. It's not a technology for replacement, but a technology to be used by the expert, to support the expert. And all of this is done with very high security standards because we anticipated the European regulation, which will actually be entering into force in a few months' time. This project, and this is being a project that's not carried out by the ministry, is quite well thought out, shows that there can be a territorial equity that reduces timeframes, reduces distances, and allows patients to have access to healthcare as swiftly as possible and whenever they need it. My second example is a partnership that was set up by the agency Expertise France with the Rwanda Medical Center on a project called Empowering Community Health Workers. This project will last 3 years. It was launched in 2025. It targets over 58,000 community health workers in Rwanda with funding of 2.9 million euros over the period. In this project, AI is used at several levels. It supports diagnostics. It is used in the vocational training for health workers. It is used in geolocalization of these health workers. It adapts the pedagogical content to individual needs. And it allows for matches to be made between doctors and patients, depending on gender and age. So you see that it can have very positive impacts vis-à-vis health workers who gain in competencies, in knowledge, in effectiveness. And it's often women in rural areas who have therefore access to health care. Public health care is the interface of three things: acceptability by the populations and two others. And thanks to these two examples, I reach the following conclusion. AI is a tool that is amazing in terms of integration. So data drift, algorithmic bias, all of this is essential. And like any other tool, it is not good or bad at the outset. It is how it is used that matters. And so we need, as is the case always in health, to have health reasoning and medical reasoning. Thank you. Thank you for having reminded us, and each of you has done so, what the conditions are for AI to be used with a view to reducing inequalities. Now, we've spent quite a lot of time talking about this subject. Now, what I would like to now do is give you each an opportunity to underscore what you believe to be the priority to keep in mind as policies are set up regarding AI. What, according to you, is the main thing to keep in mind as these policies are set up? Dr. Lazarus. Maybe that was a very difficult question to answer. No, not that difficult, but there was so much that could be said about the topic. I think that perhaps the most important thing is to manage to strike the right balance between creating an ecosystem that is very open, because you need innovation, you need research, you need risks to be taken so that people create algorithms, and you need mistakes to be made. Some things will work, some things won't, and that's absolutely fine. And in parallel, as I mentioned earlier on, you need to keep an eye on the resources that you're injecting into it. So you need a regulatory framework, an ethical framework, a methodological framework in assessment, not only the assessment of the performance of the algorithms, but also the impact on the people right through to the last mile, and including on the most vulnerable, and keeping in mind, as I mentioned earlier, the balance that needs to be kept. And it's the role of the health authorities and the health centers all over to do that. Thank you so much. Dr. Charles.
Thank you very much for the question. For me, I think we need to look at AI and the use of it, not just from an equity perspective in terms of it's not just a value, but it's a process. For me, it has to be inclusive. And we need to make sure that, the voices of the communities, of the end users is really there as well. So how do we ensure inclusivity? How do we ensure sustainability? And how do we ensure impact? As has been said here, there's so many things that is going on in the ecosystem in terms of funding. We need to be efficient. So how do we ensure we use AI in a manner that is efficient, in a manner that causes optimization, and in a manner that does no harm to the users?
Merci beaucoup, Monsieur le Ministre.
Thank you very much. Honorable Minister. Well, I would like to go back to something that's very important for us now in Africa. We absolutely need, and we're working on this at the moment with the African Agency of Medicines, is to create mechanisms for validation. Check that the tools are fair and secure. And we need to demand, and I insist on this, demand representative data. We need transparent algorithms, and especially the involvement of marginalized communities. Those are the key points in my mind. And if we move in that direction, then I think that the continent will be able to welcome these innovations, will be able to make them theirs. I've heard you speak before about new forms of colonization, and I hesitate to use that term coming from a formerly colonized country, but ownership and sovereignty are necessary so that our systems can respond. Well, thank you for that additional information. And yes, it is important to underscore, it was briefly broached, the importance of a fundamental data. You can't create AI if you don't have digitalized data. Sometimes we forget about this. Ambassador Batista was telling us earlier on about the M300 project. Maybe we need a project to ensure that we have digitalized data and also take into account cultural and linguistic specificities. And this is a perfect link with the discussions that we'll have tomorrow on this topic. Dr. Sidibé, yes, I just wanted to say very briefly that this discussion reminds me of a very important sentence by Gramsci. Every time we speak of these tools, I am reminded of it. The old world is dying, the new world is taking its time in coming about. And in the meantime, we see monsters appearing. So how do we take ownership of these monsters? How do we ensure that they become elements that can accompany our development process? It's very important. Well, thank you. Thank you so much. A round of applause for our panelists. And as far as I'm concerned, I now give the floor to Dr. Dayo, who is going to introduce the second panel.
A round of applause for the panel again for setting us up.
Vous pouvez donc applaudir à nouveau pour ce premier panel. Nous avons un quart d'heure de retard. Et nous avions commencé un quart d'heure en retard, mais nous avons une pause café. Donc, je vous propose donc de prendre le café et de revenir avec dans la salle. Évidemment, vous pouvez faire une petite pause si vous avez besoin d'une pause technique. Il y a les toilettes sont juste à l'extérieur de la salle. Donc, nous allons reprendre maintenant tout de suite avec la table ronde numéro 2 qui sera modérée par Monsieur Gadjou du Fonds mondial. Donc, petite pause de 5 minutes. À tout de suite. Nous allons reprendre à 4h35 exactement.
All right. I hope the translators, okay, yeah, so. Thank you all very much for making it back in time from the break. We will go right to the next panel, which is going to discuss the subject of building trustworthy and sustainable AI for health. The panel moderator is Mr. Eric Gaju from the Global Fund, which of course are landlords in the building, but obviously as Global Fund has been a significant global health initiative, and like everybody else, are also keen on the subject of AI. So over to you and your panel. Merci beaucoup.
Bonjour, bon après-midi.
Good afternoon. As our CEO just said, I'm delighted to moderate this session. My name is Eric Gaju. I work for the Global Fund. I'm a digital health specialist, and I am delighted to introduce our panelists, starting with Mr. Samir Pujari, digital health expert at the WHO, in charge of AI at the WHO. He studies AI initiatives worldwide in the area of health, 75 countries worldwide. He monitors work going on in other organizations, WHO, ITU, WIPO. As the first panel didn't include any women, this time we have Mariam Touré with us. Could you join us on the stage, please? Mariam works with UNITAID. She started her career studying HIV and worked in public health initiatives throughout Africa, and has also worked on quality improvement of tuberculosis programs, and is working on digital health, and is in charge of the tuberculosis portfolio at UNITAID. We also have Mr. Moussi from the ITU here in Geneva. He has prepared many standards. We'll talk about this. It's one of the challenges we face. He is information technology engineer, has contributed to over 200 standards recognized worldwide. And Dr. Giovanni Camilo Gutierrez is going to join us online. Giovanni is an AI expert, co-founder at SRL Associates, has worked on pandemic issues, has contributed to many initiatives in the area of ethics and AI. And last panelist, Cedric Degbo, REMA CEO, medical practitioner, and he's in charge of a platform connecting patients with health providers, REMA, which has become one of the main providers throughout the continent. So to start, we are going to touch upon the topic of how to build trustworthy AI for health. So how to strengthen trust which is lacking. We need to strengthen it sustainably. For health, AI is evolving very fast. There are many taboos, many question marks. Of course, because humans are intelligent. So there are many questions and question marks with regard to AI. How can it help us in diagnostics? How can it help us in decision making, to take informed decisions? How can it help us have more advanced diagnostics? How can we ensure it benefits equity? How can we build trust? Throughout the session, we will try to see how we can validate and monitor AI tools through policies, especially together with our expert from the ITU and benefiting from each and everyone's expertise. So first question. So first question for Mr. Pudra.
The biggest gap in governance and what kind of regulation are most urgently needed for country from low and middle income countries? And you feel free to give some of the example of ongoing efforts, and including those you do with other organizations like ITU and WIPO, and on the level, national level, but international level.
Thank you, Eric, and good afternoon. And I'm quite pleased to see so many people still sitting here on a Friday evening and listen to the AI part of it. And I think it's important because AI is here. I mean, we are talking, it's very timely. It's here, it's already making an impact. And so where do we see the possibilities and where the gaps is something that has to be discussed and understood very well. I'm going to point out two critical areas. Governance as the first one. There are flashy tools coming out, the technology is growing rapidly, but the countries, the infrastructure is not ready to accept it. We have seen several studies, several BCGs, McKinsey's have put out saying there's a massive gap in governance readiness from AI perspective. I'll give you an example. During COVID itself, when contact tracing was identified as a key protocol for tracking COVID cases, we did not first have the technology. Google and Apple were not talking to each other. And when they started talking, countries could not deploy it because the data transfer protocols and the AI governance was not existent. And so we risk that today also. There is so much technology coming out. The computing is increasing tenfold. And if we can't have the governance ready, the regulations right in place, we've lost the opportunity. So I think as the global community here, the key angle that we need to focus on is regulation. And when I say regulation, the governance, there are three parts to it. First is regulations, having the right regulations that are adaptable and acceptable, that can be deployed, allow for deployment of the AI. It's not business as usual. And therefore, the regulations have to come together. And there is an effort. In September, about 50 of the global regulators are coming together in Seoul, in South Korea, to meet and discuss AI implementation. So that action is happening, but we all have to be part of the discussion. Second is very important is ethics. And this was discussed in the first panel. Without the enforced ethical approaches of AI, we risk ourselves to create the broad equity gap. And that's, I think, something we have to control as global leaders. And third is evaluations and benchmarking. And as a global community, again, we have to look at how do we benchmark these specific tools and localize them. So the three areas that we're looking at is governance, evaluations, and benchmarking. And finally, what the point I want to make is to rethink investments in AI. You're saying AI is here, we want to do things, but if we can't rethink the way investments in public health are made or investments are made for health services, we will not be able to establish that governance. And just on that note, what we are doing, so this is what are the challenges. What has happened, and we have Dr. Bilal here who's been a visionary on this part. In 2018, at the AI for Good Summit, the first time a focus group was set up to look at how AI can make an impact. And over the 4 years, a group of over 100 experts studied together that led to the culmination of a global initiative on AI for health. The 3 UN agencies, WHO, ITU, and WIPO, have set up a program where we're creating normative guidance. There's already a regulatory guidance out for member states to apply and deploy. It's about making it happen now, investing in implementation. It's about creating benchmarks for specific tools, the TB CAD as part of the whole work, cervical cancer screening, malaria diagnostics. I mean, there are opportunities which can help us reduce the costs of healthcare delivery and speeding up the processes. The second part of this work is bringing together networks so we don't create verticals as we have done in the e-health, digital health space. So it's very important, and this is what the Global Initiative is doing. We have now convened over 500 stakeholders as part of this global initiative, and we need to grow so that we can share knowledge across rapidly. And this is a call for this group that if there is interest in AI, I think you need to join hands and work together so that we can make 1 + 1 = 11. That's the speed we have to go at for AI. And finally is actual implementation, the localization. If we can't take all of this to the localized level, I cannot adapt it. We cannot use ChatGPT to be used for every single place. It has to be localized for the contextual settings. I think that is a focus that we have to all work on. So I think that's what the global initiative is working on. And I encourage everyone who's working on AI, who's interested in AI, to come join hands so that we can replicate that speed faster.
Thank you very much, Mr. Samir. Je tourne à droite. Mariam Touré.
Turning to my right.
And you are leading digital health. And can you share with us on AI product introduction in country and how the sustainability are ensured after its introduction?
Donc, je vais juste vous dire que je vais répondre en anglais.
I will answer in English because I spend my time working in English. It's easier for me to express myself in English. So out of respect for colleagues, I'll switch to English.
I had the opportunity to introduce a lot of tools. You know that in the context of a global fund, bringing products to country, the steps before that is the development of the tools and ensuring that the tools have, you know, the acceptability, feasibility, and really have the data quality that is needed for WHO to recommend this as a tool to be introduced. And this is the same thing with digital health tools, and it's the same thing for AI tools. Over the past at least more than 10 years, we have found that the health projects are much better when you pair AI and digital health with them. And now we have products that are strictly AI based. We have had the experience with introducing an AI imaging for cervical cancer. We've worked with FIND and others in the building to introduce the chest X-ray with AI. And at the very, very start of this work, you have to ensure that you're bringing a product to countries that they need and that they're asking for. We cannot design a solution for a problem that doesn't exist, and we cannot design a solution for people who are not ready or interested in that solution. So that is the first step. The second step is when I think our previous panels have talked about this, and the way the data, the AI is trained and all of these things. We have to ensure that the tools are actually able to be trained on the population that they're needed for. We found out a little bit to our surprise that something as universal as a human cervix, which, you know, of course, when you're thinking, for example, of the skin cancer, as was mentioned before, you can see immediate differences between, you know, a Black person's skin and a white person's skin. What does the cancer look like? Is it different? And we did not expect these differences in cervix from the population in India versus some of the population in Africa. And so we had to ensure that the AI was trained differently and had to come back to the ethic review committee of WHO to ask for increases in population for different teams. And so that way we're ensuring that the AI was trained to bring them the results that they need and that there were results that they can count on. So that is the second step. The third thing is when we're designing tools, it's not just about having something that works well. every project that comes needs to have some form of cost effectiveness and all of these other maybe softer side of the science done to make sure that the country can afford it, to make sure that compared to the standard of care, this new tool, which is good and works well, is going to save them more time, it's going to cost less, so that in the long run, they can see the benefit of making the switch from the standard of care to this new tool. And lastly, there's always the human side, which was also discussed. The training can be intensive to make sure that people who were not used to digital technologies are now not only becoming more comfortable with the digital technology, but are trusting AI to do part of their job. And I want to also make a final point around that, where perhaps in some countries, there's some concern about AI taking jobs. We know for a fact that in Africa, almost all of the countries have a lack of healthcare staff for the number of people. You see the lines from morning until night, and doctors are seeing patients in 5 minutes, no more than 10 minutes for very complicated cases. And AI is able to help them diagnose faster and to do their job better and really bring that equity to the population. And so those are just some of the key points so that I don't belabor the point too much.
Yeah, thank you very much, Mariam. I would like to check if online Dr. Giovanna can hear us, or is she connected? Can you confirm? Oh, wow, that's great. Yeah. Thank you very much, Mariam, because you just touched something in terms of like health workforce and communities. And je voulais peut-être te poser la question en français. D'après votre expérience, il y a le souci de confiance dans les outils de diagnostic basés sur l'IA, mais aussi, d'après votre expérience, quels sont les facteurs permettant de renforcer cette confiance au sein de professionnels de santé, mais aussi des patients, mais aussi dans les communautés?
Merci, bon après-midi. Merci à tout le monde, aux organisateurs pour l'invitation. Et oui, pour répondre, en fait, bien en relation avec ce que Madame Touré justement parlait de ça, c'est très important de revenir sur l'idée que l'IA est un outil et qu'il faut remettre au centre l'humain et dans notre secteur, les patients, les travailleurs de la santé. Et donc, à partir du moment où on va utiliser un nouvel outil, il faut être très transparent par rapport à la communication, dans quel cadre on va utiliser l'IA. Et dans mon expérience, les meilleurs cas d'usage sont quand le système est développé ou co-design avec les parties prenantes, c'est-à-dire la population qui va être affectée et les personnes qui travaillent dans la santé et les décideurs, par exemple. Parce que à partir du moment où on prend le temps d'expliquer dans un cadre où l'outil va s'intégrer dans le système de santé, et c'est une aide au corps médical, ça ne va pas remplacer le corps médical, ça permet aux gens d'avoir plus confiance et plus de l'adopter. Et pour ça, il faut revoir les principes d'IA responsable, c'est-à-dire la responsabilité pour comprendre s'il y a un problème, qui va être responsable, la transparence dans la documentation du développement du système de l'IA, la sécurité des données privées, donc confidentialité et sécuriser où sont physiquement les données, donc ce qui revient à la souveraineté des données du pays. Et aussi, à partir du moment où on doit adresser les attentes de cette population locale, alors dans ce cadre-là, la population, les patients, les travailleurs peuvent être assurés s'ils sont formés, s'ils sont sensibilisés par rapport aux bénéfices, mais aussi aux risques de l'utilisation de l'IA.
Oui, merci beaucoup, Dr. Giovanna. And then back to the room with Dr. Bilal, and I think you are among the person who will be helping us, because as we all understand, artificial intelligence in the level of being adopted in many sectors, including health. But how can ITU technical standard work to help and the adoption of AI in health sector?
Merci beaucoup pour la question. Merci pour l'ambassadeur Henri et pour le PDG de FIND pour cette aimable invitation cet après-midi, vendredi à 17h. Et je suis vraiment ravi de voir une audience pareille. Et donc, pour commencer, j'aimerais vous faire un petit cadeau. Alors, le cadeau, c'est la publication qu'on vient de mettre sur notre site web de l'UT qui s'appelle « Façonner l'intelligence artificielle dans le domaine de santé du point de vue éthique, régulation et normalisation ». Donc, c'est un rapport que mon cher collègue Samir vient de parler de notre travail sur l'intelligence artificielle dans le domaine de santé. C'est un parcours de 5 ans qui a commencé lors du sommet AI for Good en 2018, qui a été lancé par le directeur général de l'OMS et le secrétaire général de l'UT pour créer un groupe spécialisé de médecins ou du corps médical et d'experts dans le numérique pour vraiment travailler tous ces aspects d'utilisation de l'intelligence artificielle dans le domaine de la santé. Ce groupe de travail qui a vraiment inclus des médecins, des chercheurs, des sommités dans le domaine de santé et dans le domaine du numérique, a travaillé pendant 5 ans dans plusieurs pays, nord et sud, est-ouest. Le travail a été soutenu par la Fondation Botnar. Donc, le travail a été soutenu par la Fondation Botnar pour avoir plus d'inclusion et de diversité dans l'aspect de données, par exemple, que le PDG de FIND a parlé dans l'ouverture, tout ce qui est bias dans le domaine de data. Donc, ce rapport que vous trouvez sur notre site web aiforgood.itu.int résume tous ces travaux. Le travail sur le côté éthique dans AI for Health, 3 rapports sur les aspects de régulation, une dizaine de rapports techniques qui travaillent sur les données, la labellisation des données, la vérification des algorithmes, le benchmarking des algorithmes, ainsi que des cas d'usage, use cases, une dizaine, je pense, de cas d'usage. Mais également, on ne s'est pas arrêté à publier ces 36 rapports du Focus Group. Nous avons également un travail sur le open source, open code, qui permet vraiment aux États, aux hôpitaux à travers le monde de travailler sur ces cas d'usage et pour pouvoir faire du benchmarking, l'évaluation de ces applications de AI for Health qui sont dans le domaine de diagnostic, etc. Donc, ces normes internationales qui ont été développées par l'OMS et l'UT ont fait vraiment l'objet de travail très détaillé que je pense servira à travers l'initiative globale qui est avec l'OMS, l'UT et l'OMPI, parce que l'OMPI a un travail vraiment sur les startups et l'innovation, les brevets d'invention dans le domaine de AI pour la santé. Donc, cette initiative globale permettra de mettre tous ces rapports en exerce dans les pays qui ont besoin. Alors, le besoin aujourd'hui, même lorsqu'on a commencé ce travail, il y a un manque de 10 millions de professionnels dans la santé. 5 millions de médecins et 5 millions d'infirmiers corps médical. Et donc, le manque est immense. Et l'intelligence artificielle a un rôle très important pour combler ce manque. Et c'est là où on a essayé de faire ce benchmarking de toutes les solutions AI pour la santé afin d'apporter cet élément d'assurance et de sécurité, de validation d'utilisation de l'intelligence artificielle dans le domaine de la santé. Je finirai par dire que l'AI ou l'intelligence artificielle dans la santé n'est pas uniquement dans ce secteur-là. Je pense que le collègue dans le panel précédent a parlé de la santé dans le sens global, dans la détection des catastrophes naturelles. On utilise l'intelligence artificielle. Et donc, on avait un autre groupe spécialisé qui a publié ses travaux dans la détection précoce des catastrophes naturelles et qui, par conséquent, sauve des vies. L'IA dans l'agriculture, parce que beaucoup de problèmes de santé et de famine viennent parce qu'il n'y a pas suffisamment de production dans le domaine agricole. Et là, on a travaillé avec les FAO sur AI, IA et les droits, l'intelligence, l'Internet des objets pour l'agriculture. Donc, il y a vraiment un balayage qui est assez large pour l'utilisation de l'intelligence artificielle pour la santé. Et je finirai par dire, pour inviter tout le monde à nous rejoindre la semaine prochaine dans le AI for Good Summit du 8 au 11 au Palexpo pour continuer ce dialogue sur les bonnes utilisations de l'intelligence artificielle. Merci.
Merci beaucoup, Dr. Biller. Et notre dernier intervenant, c'est Dr. Sediko Degbo. Je crois qu'il est en ligne. D'après Dr. Biller, il nous disait qu'il y a beaucoup d'implémentations dans les différents secteurs, y compris la santé, mais spécifiquement pour le diagnostic. D'après votre expérience, quels sont les facteurs permettant de renforcer cette confiance qu'on parle dans les outils de diagnostic, mais basés sur l'IA parmi les professionnels de santé, et aussi dans les patients, mais aussi dans la communauté?
Merci, Monsieur Eric, pour la question, et je remercie également l'OIF et le PIN pour l'invitation. Donc, concernant la question du renforcement de la confiance entre les acteurs, on va dire, du système de santé, aujourd'hui, notamment en Afrique, qui est le continent que je connais le mieux, il y a plusieurs acteurs, en fait, plusieurs facteurs. Ces facteurs-là dépendent évidemment des acteurs, du point de vue des acteurs. Donc, moi, il y a 3 acteurs qui m'intéressent le plus, c'est vraiment les agents de santé, ensuite la population générale, donc le patient, et in fine, les institutions, notamment sanitaires. Donc, si on prend les agents de santé, il y a comme premier facteur, en tout cas selon moi, de renforcement de confiance des agents de santé en IA, qui est la fiabilité. Il faut reconnaître aujourd'hui que le risque d'erreur de diagnostic, il est présent en termes de pratique humaine de la médecine, et ce risque-là ne disparaît pas non plus avec l'intelligence artificielle. Donc, pour qu'un outil basé sur l'IA, un outil de diagnostic basé sur l'IA soit accepté, en tout cas ait plus de chances d'être accepté par les agents de santé, il faut absolument que les performances de cet outil-là soient supérieures aux performances, notamment cliniques, de l'humain. Pour moi, c'est le premier facteur. Il y a également le facteur transparence de l'outil diagnostic basé sur l'IA. La transparence ici, je le vois, moi, dans le sens du score de probabilité. Il faut afficher aux professionnels de santé, en tant que concepteur d'outils IA dans le domaine de la santé, il faudrait qu'on affiche aux professionnels de santé le score de probabilité de justesse du diagnostic que l'IA propose aux professionnels de santé. C'est super important parce que d'une part, ça conforte le médecin, ça aide le médecin dans son analyse, mais d'autre part, ça le conscientise par rapport au fait qu'il a une responsabilité, parce que l'outil a une marge d'erreur. Donc, lui-même, il a une responsabilité. Je viens donc sur le troisième point, c'est la responsabilité du médecin, en fait, de l'agent de santé, qui est pour moi le troisième facteur le plus important. L'IA ne vient pas remplacer le médecin, c'est un outil d'aide à la décision. Et le dernier facteur, pour moi, concernant les agents de santé de confiance, c'est vraiment l'approbation que l'outil en question a auprès des autorités compétentes et également auprès des autres confrères. Donc, la recommandation venant des pairs peut aider à l'adoption et à la confiance des professionnels de santé dans ces outils-là. Pour finir par les patients, pour moi, c'est le consentement éclairé du patient. Il faut que le patient donne son accord au professionnel de santé d'utiliser un outil d'IA dans les soins de santé qui le concernent. Moi, c'est le point le plus important pour le patient. Et ensuite, concernant les institutions, il faut que les outils aient fait leur preuve d'un point de vue santé publique. Parce qu'on n'est plus à l'échelle individuelle, là, on est à l'échelle d'un pays, d'une région, etc. Donc, il faut que les outils aient un impact positif sur les indicateurs de santé publique en termes de gain de temps dans la prise en charge et en termes comment dirais-je, d'amélioration, enfin de réduction des erreurs médicales, notamment sur le continent africain. Donc voilà, pour ne pas prendre beaucoup de temps, c'est les quelques éléments que je voudrais évoquer en ce qui concerne la confiance.
Merci beaucoup, Dr. Cédric. En restant en ligne, je vais vous demander peut-être la deuxième question très rapidement. Comme quelqu'un qui est PDG d'une entreprise qui implémente l'IA, à ton avis, comme on vient de le dire, les IA sont entraînées basées sur les données qui viennent des pays développés parce que c'est eux qui ont peut-être introduit la technologie, mais aussi pour être implémentées dans les pays en voie de développement. Quels sont les facteurs ou bien comment valider cette implémentation pour le pays en voie de développement alors qu'ils sont entraînés par les données qui sont venues de pays développés? Très rapidement.
Ouais. Je pense que ça a été nommé hein, notamment lors du panel précédent qu'il faut contextualiser les données, notamment locales. Donc, évidemment, on est obligé aujourd'hui, à cause du manque de données numérisées, notamment sur le continent africain, de prendre comme base les données provenant des pays développés. Ça, on n'a pas le choix. Mais il faut rendre ces données représentatives sur le continent africain en les contextualisant. Donc, faire une collecte de données locales. Là où moi, je pense que peut-être ma position diffère un peu de celle des autres, j'en sais rien, c'est sur le local que moi, j'aimerais insister. Parce qu'on dit local, on peut dire local en pensant africain. On peut dire local en pensant pays, on peut dire local en pensant département, district ou ville. Et la réalité au sein d'un même pays peut vraiment sensiblement différer d'une ville à l'autre, d'une région à l'autre. Donc, pour moi, je ne crois pas du tout à la notion, qu'on parle de télémédecine, de santé numérique ou d'IA en santé, je ne crois pas du tout à la centralisation du pouvoir de la gouvernance des outils d'IA de manière polarisée. Je crois plutôt à la décentralisation. Donc, il faut que les États centraux décentralisent le pouvoir de gouvernance, donnent le pouvoir aux collectivités, notamment aux mairies, aux municipalités, pour que chaque municipalité puisse prendre des décisions, évidemment dans un cadre général, réglementaire, technique, normatif, mis en place par le pays ou les groupes de pays, mais absolument, il faut que ces données-là soient, enfin, la gouvernance soit au niveau de la collectivité, incluant également les acteurs du secteur privé, qui sont souvent très souvent oubliés par les autorités. Donc voilà mon point de vue par rapport à cette question-là.
Merci beaucoup, Dr. Cédric.
Je vous en prie.
Aussi en restant en ligne, Dr. Giovanna, pardon, la même question, mais en se focalisant pour les risques d'appliquer ces systèmes de l'IA à des populations ou des systèmes de santé pour lesquels ils n'ont pas été conçus. Quel est votre avis là-bas?
Merci. En fait, oui, comme épidémiologiste, il faut se rendre compte qu'en prenant des données qui représentent des populations qui peuvent être foncièrement très différentes, avec la prévalence de maladies chroniques, par exemple, différentes, ou des marqueurs génétiques très différents, on ne peut pas assumer que l'outil va fonctionner aussi bien dans un autre contexte. Donc, comme disait Dr. Cédric, effectivement, c'est vraiment important de prendre en compte le contexte local. Le contexte local est clé. Donc, c'est pas seulement d'un côté, bien sûr, la performance clinique au départ testée et les fournisseurs vendent l'outil, mais aussi les tester dans des, genre vraiment dans les populations locales, refaire une évaluation pour être sûr que l'outil, par exemple l'outil diagnostic IA fonctionne dans ce cadre-là. Souvent, par exemple, si les bases de données qui ont été utilisées pour entraîner le modèle, par exemple, n'ont pas des enfants, et après c'est utilisé chez les enfants, sans test, ça peut créer des problèmes, ça peut mener à des discriminations, ou par exemple, s'il y a certaines intersections comme âge, genre, maladie, handicap, etc., qui ne sont pas représentés dans la base de données, ça peut vraiment mener à des discriminations par rapport à l'utilisation de l'outil. Donc, c'est vraiment important de recadrer l'utilisation de ces outils, d'adopter ces outils en ayant en tête ce problème. Idéalement, il faudrait des données souveraines de l'endroit où l'outil est utilisé. Mais bien sûr, c'est très difficile parce que ça demande de l'infrastructure, ça demande du compute, des données, des modèles, le cloud, et c'est très, tous ces assets sont très polarisés dans le monde, dans un contexte où il n'y a que quelques pays qui ont les finances pour ça. Voilà. Merci.
Merci beaucoup, Dr. Giovanna. I'm now back to the room, Sami. Briefly, can you let us know if there is any collaborative approaches that can be suggested, which can make this AI-driven ecosystem more sustainable, but also resilient, such as sharing best practices? You said that you've been working with WIPO, ITU, and other. Can you let us know those approaches that can be suggested in maximum 1 minute, please?
Yeah, of course. I think if you ask the question, if there are collaborative approaches, I think that's the only way to work forward. And there's several. So, I mean, depending on which area you're working on, there's 6 domains of AI. Vision and computer is growing very rapidly. There's a lot of evidence we can cross-pollinate. X-ray diagnostics versus diabetic retinopathy uses the same technology at the core of it. And I think that's why there's a lot of replication. The predictive models for malaria come from predictive models for other domain areas, climate changes and predictions. So I think there's a lot of overlap in terms of possibilities of doing it. And the simplest, and that is the whole onus of the global initiative that we created, is so that we don't create the verticals that we have seen in e-health, digital health, and several other digital domains. We want to bring that together. And that's why I'm urging, and I'm sort of requesting everyone, if there's interest, don't recreate the wheel, come together, join hands. We have an infrastructure global initiative, which also taps into the broader AI for good community. I mean, that's how it was set up. So I think that's a way of connecting and building. So I think that's the only way to move forward if you want to win.
Thank you very much. Coming back to the room again, our sister here, Mariam, can you share with us some access consideration that can help to ensure the sustainability of the AI tool that we are referring to?
Yeah. I'd like to bring us back to a previous comment that was made in the first panel, where I don't know if it was Dr. Michel who said, that equity cannot be an afterthought. I wanted to say that also access cannot be an afterthought. So when it comes to the access, what I wanted to share is that in this context where we're most likely moving away from big global organizations funding a lot of projects, buying a lot of tools, and kind of balancing more with countries buying more of the tools, the cost of these tools is going to be ever more important. And what Unitate has done in the past, and we're doing now, and will most likely do in the future, is working with manufacturers, working with innovators to make sure that the access terms for the tools are transparent, making sure that the access prices are going to, like, the prices of the process, the prices of the products are going to be such that they include service, they include just the full package of what the product will cost are taken into account, so that countries, when they're buying new tools, that they're buying tools that is not going to cost one thing for Philippines, cost another things for Mali and Burkina, and they don't know between them who's paying more, and that they could have gotten a better price. This has been the case for diagnostics, and it has been the case for treatment, and it has been a case for the COVID vaccines also, as we've seen. So just the access piece is really around really the key principle of having transparency among us, and thinking about the access provisions early on in the process.
Yeah, thank you very much. And the last not the least, Dr. Biel, can you share your thoughts on challenges and opportunity from ITU perspective as the leader in terms of regression, but also for enabling trustworthy and sustainable for AI in health sector?
Thank you very much. I'll answer in English this time, for also to give the interpreters a bit of a break. But the you know, the more seriously, the topic of AI for health cannot be achieved without connecting the 2.6 billion people who are not connected today, and the institutions, the health institutions that are not connected, and the healthcare records, the health records of patients that are not in a digital form. If everything is still on paper and it's not connected, and we don't have electricity and we don't have connectivity, we cannot be talking about AI for health. So our mission in ITU is to connect the world, and we've been trying to work really hard on reducing that 2.6 billion unconnected. But also it's about a sustainable digital transformation. So once you're connected, you need to have valuable and meaningful connectivity. And that's where digital transformation in the healthcare sector, to digitize hospitals, to have digital health records, then would become meaningful for AI to work on the data. Because without the data, you cannot have any AI applications that are meaningful for every country. So I think those are the key challenges. We heard the electricity from, I think, the ambassador from Chad as kind of the basic infrastructure, connectivity next, having the data centers, having the data collected and annotated that is locally significant and locally meaningful for various skin colors, various cultures, various local realities, and then using all of the products that we have developed jointly with WHO and WIPO to be able to implement AI for health solutions that will have real impact on the patients in the village that is the most remote, that does not have a doctor, does not have a nurse, but might have a smartphone with a connection. Thank you.
Merci beaucoup, Dr. Jubier. Pour conclure, on a capté quelques informations, notamment la question de confiance, qui n'est pas quelque chose comme fonctionnalité à être entraînée ou programmée par l'intelligence artificielle, mais aussi c'est quelque chose qu'on construit par une conception qui est inclusive. Je crois qu'il aussi doit être transparent et aussi d'une façon responsable. Je remercie à nos panélistes. Thank you for all panelists present here and online. And you share your expertise. Vous avez partagé votre expertise en domaine de l'IA, mais aussi pour la normalisation, l'implémentation, même pour l'implémentation au niveau pays. Espérons qu'on va continuer à aller vers l'avant, ne pas avoir peur de l'IA, mais aussi, comme Dr. Biller nous a dit, il y a la semaine prochaine, là où on va avoir le forum pour AI for Good, mais aussi le week-end, je crois que Find nous a réservé quelque chose pour continuer les discussions. Merci aussi pour le public. Merci. À plus.
Thank you very much, panelists and moderator. This very important subject of how to build trust and sustainable AI for health. So yes, we are quite behind in time, and I'm really grateful to see so many people still here now that I'm standing here. So we will go straight to our last panel. This is the panel standing between us and cocktails. Hint, hint. This panel will be, panel 3 will be, talking about the next thing, really. So we've heard about trustworthy, what to do to build trustworthy systems. Now the question is, what will it take? Data, talent, system readiness for AI in health. And this panel will be moderated by Mr. Pradeep Kakaktil from IX. I will leave him to introduce the panelists from the Global Fund, from RBM, from Gavi, from FIND, and of course from the private sector. Thank you, Pradeep.
Thank you very much, Dayo. Maybe if I can ask our panelists to please join me here. And Sarah, Zaidi, please do join. Come. We have an amazing panel, but I also want to recognize all the wonderful people who are still in the room. Let me try and ask you, how many of you represent the public sector, ministries, missions here? Okay, wonderful. Thank you for being here. How many of you are from international organizations? Okay, okay. How many of you are from the private sector? Okay, there's one here. Anyone else? Okay, online. Thank you. For those of you online, please do in the chat, if you can just put in who you represent, whether you're from the public sector, private sector, international organizations, and civil society organizations. Anyone from the civil society here? Okay. Okay. Let me also ask you another question. Sorry, I know we have very little time, so I'm going to come back to you very quickly. How many of you are using AI daily? How many of you don't know that you're using AI daily? Okay, great, because everything that we are doing, even if you're using your Gmail or anything, there is an AI or WhatsApp or anything. So it's been a fascinating conversation earlier. The two panels have actually answered the two questions that was top of my mind, which is, are there solutions? Can AI really help bridge the gap in innovation? So that's a gap in access to healthcare, not innovation. Can it innovate to get access? The answer was a resounding yes. Do we have the systems to govern so that it's ethically available equally to everybody? The answer was probably a big maybe, yeah, which is great. But what will it take to get there? And that's what this panel is going to be answering. Let me start with Sarah, with you. Sarah is the manager of the data initiative for RBM, and as an academic earlier with the University of Geneva. And I was fascinated. She's one of the awardees who designed a brain and computer interface. I have lots of questions on that. I'll come back to you on that later. So some amazing things to talk about. Sarah, what I would love to ask you is really about data is absolutely critical. That's the oil for AI. But when we start looking at the whole building, the building blocks for AI, what are those essential elements from your experience? Where do you see we should be investing the most? And how can we really ensure that the low and middle income countries have the resources needed to build that data ecosystem? We have 3 minutes roughly. It's on.
Thank you for the questions. The first thing I would say, yes, data, and we have been talking here about data governance. So all the mechanisms that go behind what relates to the numerization. And I would say that there are many opportunities even there, because we cannot confuse the status of low and middle income countries, there are differences between them. There are differences in the level of low income countries. Some of them are well advanced, some of them are behind, and the same for middle income countries. So it's not one suite fits all. That's the first thing. Second thing I would like to say is, it depends on what you want to say. We were talking about the need to, that AI cannot be based on paper records. Of course, it cannot. But we have AIs nowadays, the large language models. Many of them are very much capable of extracting information from paper-based records and transform them into databases. So we need to, when we ask this question, we need to say for what purpose. That's the first point. If we want to go to an advanced prediction model, like the one that Dr. Michael was talking in the first panel, when we want to anticipate an outbreak of malaria based on climate patterns, then we will need a lot of resources to invest. If we want to make the numerization of the records, of the paper-based record, a small investment can still make a huge difference and prepare the basis for AI in the future. So I would say that we need to go step by step and with a very much informed decisions about the country situation, and starting by educating the people. We have been talking about trust, yes, but trust on what? There are so many different things that are done on AI. We have support vector machines, we have large language model. The level of reliability of this approach is very much different as it is for the application. So if you have an error, recovery, a document in paper is not the same as having a diagnostic error. So we can start investing in the cheapest of the approach that is still are very impactful, and then go ahead and start building more essential structure. Structure, we have been talking about power outage. We have been talking about interconnectivity, which is crucial. Many countries, yes, we cannot reach the last mile, for instance, which is crucial in malaria, because this village, they have no internet. Still, we have funds. So not everything needs to be AI-driven, even though AI can help us a lot. I will stop here not to take more time.
Thank you very much. Maybe let me turn to the audience. Everybody's spoken about electricity and power and connectivity. Do you know what percentage of health facilities have electricity, reliable electricity? Low and middle income countries. It unfortunately seems to be very, I know there are country differences. Any guesses, any 30% has reliable electricity? You're spot on, yeah? 70%, according to WHO, 70% of the health facilities do not have reliable electricity. And I know countries where it is 14% is all that has electricity, but yeah, that says that you need to be country specific. Thank you for that. And data has to be, that ecosystem needs to be built. There is need for investment. And Mark Tristan is the manager of emerging technologies at the Global Fund. You have worked, you have a history of working across the health industry over several years. Global Fund has been at the forefront of investing in building the health system strengthening in countries. You looked at data ecosystem strengthening that. I wanted to ask you about what is, if you can take a couple of countries, one which is really doing well, which has all the essential building blocks that you were speaking to for leveraging AI for health, and another which is still a long way to go, and to share with us what will it take for these two extremes to come together to be able to get to where we need to in leveraging AI. You can take.
That's on. Fantastic. Well, thank you, Pradeep, for the introduction. And juste d'abord, mes excuses à tout le monde de ne pas avoir préparé mon commentaire en français non plus. So I'm going to pass back into English. I mean, first of all, I think, number one, yes, absolutely, data ecosystems are absolutely key. And just to underline some of the comments that have been made already, to use a really old computing phrase, garbage in, garbage out. As it is with garbage, so it is with data and AI. And if we want to improve things, even with model performance, what do we do first? We should improve our data. So this is a very important question as a whole. And the Global Fund itself has been instrumental in supporting health system strengthening and building ecosystems in low middle income countries, as one of the, well, as the leading grant-based funder effectively. And we do have some examples. I don't want to sort of call out a great example and then sort of call out another country where there's another one, but just to point to some of the good examples and still say that even with those good examples, there's work to be done effectively. So a couple of good examples that we have. One, I think we've already heard from some other commentaries that Rwanda itself has been one of the rising stars, certainly in sub-Saharan Africa. And we can see this with a real focus on standards-based and interoperable ecosystems. And then other ideas, one that the Global Fund has been a co-sponsor of is the Health Tech Hub, which is in Kigali, where there's been a focus on, well, it's at the regional level as well, but effectively kicking off pilots and assessments, regional innovation, and also the Standards and Innovation Lab, which is really focused on interoperability. And so one of the key things is making sure that we don't have siloed data systems. We actually have things which can talk to one another and talk in the same language. We're all talking about languages effectively in terms of AI, but we've also got languages in terms of data. So we need to make sure that we can have these conversations and therefore AI can profit from these. Another example would be South Africa, which has made great strides with projects such as CAD for TB, where we're certainly seeing this outreach. I think we've supported 35 mobile radiological vans which are going around, supported with AI on this one. And we also know, as a result of this focus on screening and diagnostics, that also one surprising things. We had a brown bag here, I think, on the campus last week, and I was talking to the South African team, and they were saying one of the key things that they found was that they were noticing a massive number of asymptomatic cases that were able to identify and detect, and this was huge. And we're talking I think 40,000 cases affected on this side. So really quite a big number on this one. So that stuff coming out, and then also we've been supporting EMPLO, which is the electronic health record system, and fire standards in South Africa as well. But I've quoted those two cases. Our CAD for TB records are not hitting that backbone. So effectively, we say this thing already where we're making strides in places, there is still work to be done. And if we take these examples of where we have the digital foundations and the governance and innovation, so it's all these things coming together and the ecosystems aligned, we see this high watermark, and we're still saying, well, there's still work to be done on these things. And we look out and take the idea of AI. So I would reach out to a couple of indexers, one being the Government Readiness Index, another one being the Responsible AI Index. And we look at these areas which talk about what is needed for AI to work. And we look at, this is great. We say, okay, South Africa, Rwanda, well, they're scoring so much higher than a lot of the other countries as well. And we can't just take what works in one place and just port it across in others, but we do need to make sure that we can support sort of this growth in these areas. So there's a vast amount of stuff which is important in this area, which we can support and drive forwards, but there's still an immense amount of work to be done effectively on this one.
Thank you very much. And it's great to hear some of the examples of countries which are doing well, which have all the right systems in place. And also at the same time, what you spoke about, the language where different data can speak to each other. I think one thing which we have all learned is that for AI, simple thing like your neighbor, malaria data, the climate data doesn't necessarily speak to the health data. So how do you bring these different silos together? And that's something which we need to do a better job of. Health is probably terrible at understanding most other sectors. We love our silos. I think speaking about much of the governance conversation that was happening, it's also about the whole issue of how do we build capacities within countries to manage the data, to look at how do you use that in a ethical manner? How do you build those capacities? So I'm going to turn to you, Laura. Laura is the Chief Technology and Knowledge Officer at Gavi. You have helped so many industries to transition, use data, use technology. So my question to you is, what are the skill sets that are needed in country for the health sector to really be prepared for leveraging AI? And also, maybe if I may twist that question, how can we actually use AI to build those capacities in countries? Laura.
Thank you for that. Hi, everyone. Well, so I think when you talk about building capacity, building AI and digital capacity is really no different than building other capacity. People need to be exposed. They need freedom to experiment. They need to be interested. So using some of those approaches will get somebody and organizations, people in countries interested in AI. I think learning approaches are different for everyone. So some are visual, some are hands-on. And so making sure that there's opportunities to play around, to use things daily. I really liked your question at the beginning, like which one of us are using AI on a regular basis. And so you have to find ways to encourage people to experiment, to try. And also make sure that experimenting, if you fail, if you try something, then it's not a failure, it's actually learning for the next go around. And specifically for AI, it is, these capabilities are really evolving so quickly. I think that the information needs to be provided in such a way that it's just in time. So, you know, there's a lot going on in an LMIC, and maybe the interest and what's needed right then and there is not that capability. So making sure that there's small injections of opportunities to do hands-on when it's needed just in time is really important. So some of the things that that would work and have worked are, first, we talked about infrastructure. So it should be like on principle, any tools, any kind of application for learning and being exposed to AI offline first. So making sure that we're not dependent on electricity, on data, that it can be accessed, and this information can be accessed. The tools can be accessed when there's no connectivity or low connectivity. There are some apps that have been built that have proven that. There's some X-ray tools using AI that are operating in low connectivity environments. The other thing that I would mention is role-based training. So really understanding in that setting, in the LMIC, who needs to be trained on what, and then really focus the training on that role so that it is very applicable to what they need to do every day. And the last example I would give, or let's say advice, is think about immersive learning. So, excuse me, especially if you think about a healthcare worker who needs to know how to do a specific procedure. How can you simulate that using AI so that they are in the procedure, although it's a simulated procedure? So that immersive learning concept will really help move the needle in terms of building that capability. Because once you experience it, then you learn, and then you can do it in real life.
Thank you very much. I think AI and augmented reality gives us that opportunity to learn, fail, and you also said about fail fast and move on and build. So one of the people who I really envy his job is Aurélien Meis, who is the principal data scientist at FIND. His day job is to look out for innovations using AI that are using AI-based diagnostics and his past, he's also done some very interesting things about finding fires using visual data and also monitoring sleep. So I was fascinated by, I don't know whether you look for fires when people are sleeping, but that might be something which I'll come back to and ask you about. But Aurélien, tell me, you have seen several AI-based technologies, diagnostics emerge. Some of them have failed fast, what Laura was saying, and some of them have actually really scaled for impact. Now, if you're a country, what are the kinds of characteristics that you should be looking for when you're looking for AI-based solutions? And also for me, at the beginning of the conversation, there was a very interesting comment made by one of the panelists, which is that you don't want these solutions to be just standalone implemented from top, but needs to be owned by communities. How do we ensure that? And maybe that's a question I'm also going to ask you, Sarah, about community ownership. But also, how can we ensure that AI doesn't become a neo-colonialism by a few countries, by a few companies, which are going to take over the entire space? So, sorry, that's a complex question, but I know it's something which would be
Merci pour la question.
Brilliant.
Je vais essayer de le faire en français parce que j'ai dû chercher mon vocabulaire avant. Travaillant en anglais, j'ai dû chercher les mots en français, donc je vais essayer de rentabiliser ma recherche de la matinée au sujet des mots français. Il y a déjà effectivement plein d'outils de diagnostic basés sur le AI qui existent, notamment pour la détection par exemple de tuberculose sur les radiographies. Fine travaille beaucoup là-dessus. Il y a des outils de support à la décision, aux décisions cliniques qui sont aussi mis en place et qui sont étudiés, où il y a des projets actuellement de déploiement dans les pays. Fine, l'année dernière, a publié une revue technologique sur les outils basés sur l'IA pour la détection de maladies respiratoires. On a identifié 159 solutions. Le rapport est disponible sur notre site web. Sur ces 159 solutions, 12 seulement venaient de pays, venaient de compagnies dont le siège était basé dans les pays à revenus faibles et intermédiaires. Donc ça montre déjà que par défaut, par définition, la majorité des solutions proposées viennent de pays à revenus élevés, sont entraînées sur des données qui viennent de pays à revenus élevés, et ça pose déjà un problème de par ce design, ce fait en fait actuel. Après, il y a différentes possibilités pour essayer de faire en sorte de sortir de ce fait. Déjà travailler sur l'infrastructure des données. On parlait, vous en avez parlé déjà avant, mais justement la digitalisation des healthcare, des rapports de santé, des données de santé. Comme on disait, sans données, il n'y a pas de IA derrière. Faire en sorte de pouvoir collecter ces données pour que ces données puissent être réutilisées ensuite pour contextualiser les outils qui ont été développés dans les pays à revenus élevés. Donc il y a ce côté de contextualiser, de collecter les données, de standardiser aussi les données, d'avoir des politiques de standardisation de données à l'échelle plutôt internationale. Fine travaille aussi actuellement sur un projet de standardisation de données pour les outils de diagnostic basés sur l'IA. Donc comment faire pour collecter, partager, collecter, annoter, très important la notation des données, annoter, partager, utiliser, réutiliser les données dans le contexte de l'IA. Ensuite, il y a une partie investir sur la validation des outils, vérifier que ces outils soit les contextualiser directement en utilisant des données locales, ou tout du moins vérifier dans un premier temps que ces outils marchent, pas seulement sur des données qui viennent de pays à revenus élevés, mais aussi sur les données de pays à revenus faibles et intermédiaires. Là-dessus, Find a développé une plateforme de validation qui permet qui se concentre actuellement sur la détection de la tuberculose par radiographie. On va aussi travailler sur les ultrasons, par exemple, des poumons pour détecter la tuberculose. Mais on a construit une librairie d'images qui viennent de pays donc à revenus faibles et intermédiaires pour des enfants, pour des adultes qui sont représentatifs des différentes populations. Donc ça vient d'Afrique, ça vient d'Asie du Sud-Est, ça vient d'Amérique du Sud. Plusieurs différentes populations, et ces données ont été utilisées pour évaluer les performances d'algorithmes de détection de tuberculose sur radiographie pour l'OMS. Donc ces résultats ont permis à l'OMS de publier récemment leurs recommandations sur quels outils utiliser. pas pour les pays à revenus élevés, mais pour justement les pays à revenus faibles et intermédiaires. Et pour suivre justement sur cette histoire de collecter les données, depuis longtemps, on construit des biobanques. Ça peut être utile de construire des digital banks, je ne sais pas comment appeler ça exactement, mais c'est ce que Find a fait pour ces radiographies des poumons. C'est ce que StopTB aussi est en train de faire, je crois, de son côté aussi, de collecter des données qui peuvent être utilisées pour évaluer, mais qui aussi peuvent être utilisées pour entraîner. Et donc, justement, ces outils qui viennent des pays à revenus élevés, on a 10 000 images qui viennent d'enfants avec ou pas tuberculose dans un consortium qui s'appelle Capture. Et donc, l'idée, c'est d'en partager la moitié avec les développeurs pour que les développeurs puissent affiner leur algorithme pour les enfants. Simplement, développer l'innovation. Je crois que je vais me faire couper bientôt.
No, while you were speaking, I just did a quick search on ChatGPT. I mean, that's the source of truth these days. I said, what do audience think of moderators who go beyond the dedicated time, especially when it is between the drinks and others? It said 93.2% of the audience blames the moderator. So I'm going to cut you short, but...
Okay, I will finish short. Then I will go, we need education on the healthcare worker, but also education at the community level for the patient, that they know what system can be used and what are the limits. We need investment for, I mean, all of this work. We need a regulatory framework. And sometimes also making possible that system that has been developed and validated in other countries can be used after just a quick customization and local validation, but no need for the full
reinventing the wheel.
Evaluation.
Yeah, no, absolutely. Thank you. And I'm hoping that during the reception, we'll have an opportunity to get into a little bit more of the details of this. But let me come to your neighbor, Segbeji Junior Rubalan. Sorry if I'm getting your name wrong.
Segbeji is good.
Okay, so you have actually taken some of these solutions on the ground. You're working in 2 countries. You have an imaging solution that is helping several hospitals in Togo and Benin.
In Benin and Burkina Faso.
Benin and Burkina Faso, my apologies. One of the conversations that people talking about AI and AI-based solutions is the lack of data. For example, imaging, it's great to have a bank, but how do you find it to go to a place like Benin and Burkina Faso to find local data, images that are relevant locally, but also health sector? How many of your doctors in this room? Okay, so I can say this safely. Doctors and health sector is one of the most resistant to change. We just don't like change, right? So how is it as a private sector person going in, helping these health facilities to integrate your solution into healthcare? So 2 questions. One, data, how do you localize data and develop it for a solution like yours? And also the difficult healthcare providers.
Okay, so I have 10 minutes to elaborate.
You can use the ChatGPT to summarize it in 2 minutes.
Okay. Non, je vais parler en français pour faire un peu comme Aurélien, histoire de rééquilibrer. Déjà, merci à Find et aux organisateurs pour l'invitation. Alors, je vais un peu changer le titre qui m'a été donné là, même si c'est vrai. Hein. Bon, en fait, c'est une partie de ma vie, développer des IA avec des brevets et des secrets commerciaux pour Philips. Et c'est justement là qu'est partie une idée qui, en 2023, s'est plus ou moins concrétisée. On s'est rendu compte que les systèmes qu'on développe étaient des systèmes vraiment orientés sur des données européennes. Vraiment, que ce soit Philips ou GE ou Safran chez lesquels j'ai travaillé, après ma thèse en intelligence artificielle, c'était vraiment ça. Et du coup, la question qui était venue tout de suite, c'était de dire, mais qu'est-ce qui se passe pour le continent africain? Et quand on s'est posé cette question, je pense que sur les 3 panels, à chaque fois, et Aurélien vient de faire la même chose, quand on parle d'IA, on pense tout de suite aux images. Donc, c'est l'imagerie médicale, c'est la première chose qui vient. Et c'est légitime parce que l'imagerie médicale est une discipline qui est au carrefour de toutes les autres disciplines. toutes les autres spécialités ont besoin de l'imagerie médicale pour prendre une décision. Et quand on se retrouve dans le contexte africain, mais global de façon générale, mais africain en particulier, on se rend compte en fait qu'on est dans une phase où la population, elle augmente, plus de 50% en 10 ans sur le continent africain, mais aussi les pathologies augmentent. L'OMS dit que d'ici 2030, c'est 77% à peu près d'explosion en termes de cancer. Et donc, l'imagerie devient du coup centrale. Mais en parallèle, ce qui se passe, c'est qu'on a besoin d'environ 11 ou 12 ans pour former un bon radiologue. Et quand je dis un bon radiologue, c'est un radiologue qui n'est pas spécialiste, hein, c'est un radiologue généraliste. C'est important de le dire parce que l'imagerie, c'est assez vaste. Et donc, par anatomie et par modalité d'imagerie, il faut une spécialité bien précise, en fait. Et donc, quand on a commencé par réfléchir comme ça, on s'est dit tout de suite, qu'est-ce qu'il nous faut? Évidemment, la donnée, mais on est parti sur un acronyme que je dirais DISC, D-I-S-C, D pour digitalisation, I pour interopérabilité, S pour standardisation, et C pour tout ce qui touche, en fait, à la confiance que les gens peuvent avoir dans le système, je dirais de façon générale. Mais en fait, c'est là où on a fait l'erreur. Et c'est important, en fait, de mettre les choses en perspective. Notre erreur a été d'être exclusivement sur DISC. Pourquoi? Parce que DISC, ça parle au gouvernement. Ça parle à l'infrastructure. Je dirais de façon générale, c'est sur l'infrastructure qu'on doit faire des efforts. Et dans un premier temps, en 2023, je dirais qu'on a échoué. Notre start-up a échoué parce que l'initiative qui a été la nôtre et qui était partie du constat que je viens de faire, mais aussi du fait qu'au Bénin et au Rwanda, les deux rares pays en Afrique à disposer d'une stratégie nationale pour l'intelligence artificielle, qui est quand même une avancée majeure. Donc, dans ces stratégies, on parle d'utilisation de l'intelligence artificielle pour le domaine de la santé. On s'est dit que le terrain était mature et donc on pouvait attaquer. On a échangé avec des radiologues et ils nous disaient, on est prêt. Mais en fait, ils n'étaient pas prêts. Et c'est là le premier échec que nous, on a eu. Et je pense que toutes les discussions qu'on a faites aujourd'hui...
They were not ready because they didn't have the capacity, or is it because they were resistant to change?
C'est exactement ça. C'est plus la difficulté, l'acceptabilité, en fait. Resistance to change. C'est l'acceptabilité. Et cette acceptabilité était basée sur 3 choses, en fait, qui nous manquaient. Et c'est après qu'on l'a compris. Ces 3 choses, ça a été dit à volonté, c'est la formation. C'est le fait que les gens, on ne se rend pas compte, on parle d'IA à longueur de journée, mais on ne se rend pas compte que les gens, les médecins, et vous l'avez bien dit d'ailleurs, ils n'aiment pas les outils, ils n'aiment pas faire trop d'efforts. Et nous, l'un des éléments qu'ils nous ont dit, mais en fait, si j'ai un outil qui demande que je fasse un clic en plus, je ne le prends pas. Juste un clic, je ne le prends pas. Et ça, ce n'est pas juste des mots, c'est une réalité. Et l'autre élément sur la formation, c'est le fait que la plupart du temps, quand on regarde le syllabus de formation des médecins, il n'y a pas tout ce qui est introduction à l'utilisation des outils numériques, un ordinateur, une tablette, c'est basique, mais en fait, c'est la réalité du continent. Les gens n'ont pas ça dans leur syllabus. Et ça, c'est un vrai élément. Le deuxième élément sur le FAR, le A, qui est l'acceptabilité, et donc, il faut quand même garder ça en tête, c'est super important. J'ai entendu beaucoup de choses aujourd'hui et je suis très content parce qu'on regarde du point de vue du patient, les bénéfices du système pour le patient. Mais en fait, ce n'est pas comme ça que les gens réfléchissent en Afrique. Je suis désolé de casser un peu l'ambiance, mais ce n'est pas comme ça. Les spécialistes de la santé se posent la question de savoir qui me recommande ta solution. Est-ce que ce sont des têtes couronnées? Et par tête couronnée, je veux dire, est-ce que ce sont des professeurs, les grands noms du domaine, mais à l'échelle du pays, pas à l'échelle du continent, pas des noms européens. Ce n'est pas leur problème, même s'ils viennent se faire former ici. Ce qui est important, c'est les noms à l'échelle du pays, mais aussi et surtout, qu'est-ce qu'ils gagnent à utiliser de cette solution? C'est leur bénéfice à eux en tant qu'individus. Et ça, tant qu'on ne l'a pas compris, en fait, on manque une pièce importante du puzzle. Et c'est en ce moment-là, en mettant les deux ensemble, qu'on a commencé, nous, on a changé notre mindset. On a commencé par travailler avec les professeurs d'université, notamment ceux de la FSS au Bénin, On a bougé aussi au Burkina et aujourd'hui, avec les journées des radiologues d'Afrique noire francophone, qui est le creuset dans lequel ils se rencontrent, on est en train de créer, on a déjà commencé par le Bénin, ça le fait aujourd'hui avec la validation des modèles, mais on est en train de créer un conseil scientifique, mais à l'échelle du continent et de l'Afrique noire, pour que ces gens-là puissent travailler et être des leaders qui vont aider à pousser la chose. Et je terminerai sur un dernier point qui est super important, qui est la réglementation. La réglementation, aujourd'hui au Bénin, on a 2 éléments de réglementation. C'est l'autorité de régulation de la santé qui décide de comment les choses doivent se passer et il y a l'autorité des données à caractère personnel. Et même s'ils sont plutôt très méfiants, ils attendaient quand même qu'on ait cette autorisation-là. Et on a réussi à être les seuls aujourd'hui au Bénin à avoir cette autorisation pour collecter les données, pour les stocker et surtout pour apprendre des modèles d'intelligence artificielle sur des données. Donc, les données aujourd'hui sont collectées. Le système Shuri, la plateforme sert à plus de 5000 patients aujourd'hui. À ce jour, en moins d'1 an, on est à 5000 patients sur la plateforme. Et je termine en disant qu'au Burkina Faso, c'est utilisé par le gouvernement parce que la solution a été déployée sur le serveur et aujourd'hui, plus de 300 000 personnes ont déjà bénéficié de cette solution. Mais c'est tout un travail sur l'humain d'abord. C'est vraiment ça, c'est pas la technologie. Il faut vraiment se le dire. Donc, je termine là-dessus. Merci.
Brilliant. No, thank you very much. I think you've managed to get not just 92%, but 99% of the audience against me. But that's fine. I think those are very important points. The role of engaging academics, as well as working with the regulatory framework, which was also mentioned at the beginning. But similar to engaging the academicians, there's also the role of engaging with the communities, and that's something which StopTB partnership has probably done an amazing. You have one of the largest community-based data through One Impact, if I'm not mistaken. You've really looked at using data very creatively for AI. Sarah, over to you. Tell us more.
Okay, thanks. I'll try and keep it brief because I think I'm the last panelist for today. So yeah, I guess, for my role, I mostly work on imaging, CAD4TB, CAD4TB detection, not CAD4TB, the company. But I would say as well as the deployment of AI starts a long time before kind of the shipment of the technology into the country or the implementation. So there's the validation, of course, to make sure there's trust in the solution that it actually detects TB or other illnesses. But for TB, I think we've reached a stage where we know that it's quite accurate. It performs as well as or better than radiologists. So you're not disadvantaging people by using AI rather than a person. But there's also how do you get doctors, healthcare workers, and patients or community members to trust this intervention? So you mentioned engaging academics. Maybe as well, depending on the context, but something we work very closely on is kind of more remote areas where maybe they don't really care what the person in the capital city has to say about it. So just to give one example, we work with the transgender community in Pakistan, which is already a marginalized community, and TB is also stigmatized. So a lot of them are scared of even getting a TB diagnosis. And so maybe they're not keen to go and get any kind of screening. So by engaging there, they work on like a kind of a guru system. So you engage their gurus, their leaders, and build that trust in the intervention. And maybe they do, they have a chest X-ray and have the AI read, and you see that will encourage more people who are at high risk to come and get the screening. So I guess on the community level, that is what you can do. And yeah, I can say more, but I don't know if you have more questions to ask.
Thank you very much. I might also want to hear you speak about the partnership, because what is fascinating is also the work that you're doing in bringing the private sector and partnership with private sector.
Maybe so again, I'll talk about the AI for imaging companies in particular. I think a lot of us have talked about data and training, and I think it's very important that we don't want these companies to be extractive, where they're taking data from just say low middle income countries, and then they're using it to sell a product to high income countries. So it's very much about creating a partnership with the NGOs and with the partner. So StopTB works a lot with local implementing partners on the ground, and we partner them with these CAD companies. So it's kind of mutually beneficial. They will run the evaluations on their technology and kind of build trust in it, while the company might get endorsed in terms of they are seen as accurate. They get a market, but they're also focusing on a real solution. I think also keeping them accountable in terms of, not accountable, well, yeah, I guess keeping them accountable in terms of when they're servicing these countries, they need to be providing the support around it. You can't just transplant this technology and just expect people to use it. I think somebody mentioned earlier, you need to make sure the training's included in the price and the service and spare parts, and also the logistics of the spare parts. So in one instance, we worked in Nigeria, they had a lot of battery failures, and the replacement battery was taking like a month to ship from the Netherlands. And it's not very feasible to kind of stop screening them for a month. So we kept in contact with we kept the company accountable by linking them up with the NGO consistently. We had monthly calls, and we ended up working together with the GDF team in StopTB to have a spare parts store created in Nigeria. So then if there is a battery failure, you're not waiting a month to go and have it shipped from Amsterdam. You can get it within the country, as well as that building local capacity for support in terms of if there's maintenance failures. You don't want to have to rely on either having connectivity, like either having internet to be able to link with someone, or having someone actually fly over from quote unquote the global north. You want to have people in the country, super users or kind of highly skilled in this technology, to be able to do those basic or not so basic issues, I would say.
Thank you very much. I know that everybody is going to blame me for being late for the drink, so might as well take the blame. I'm going to give each one of you one sentence, but I want it to be a call for action, okay? Something practical, tangible that you want to see happening. I'm going to start with Mark here, but how many of you, I'm going to reveal something that's happening. I don't know if I'm allowed to. How many of you work on Global Fund proposals? How many of you have said, oh my goodness, it's not just Global Fund, every proposal is a pain? Okay, there's something that you should, okay, thank you. There's something that StopTB is working on, which is going to make proposal writing very easy. So speak to Sarah later. It's using an AI bot to write your proposal. But anyway, I shouldn't be saying that. I didn't say that in public, right? So you didn't hear me. But Mark, what is your one call for action? Absolutely point it. You can, 10 seconds.
I'll speak loudly.
No, there's also people online.
I can't speak loudly enough to go across the internet necessarily, but I think my call to action, I think resonates with some of the commentary earlier, which is, look, there's a whole bunch of us where we need to build a coalition of interest and execution. We absolutely need to align ourselves and know who does what, who hands over to whom, and make sure that we get on and do it.
Fantastic.
You took my point. Anyway, I'll go with another. I think build reasonable and solid partnerships, not only with the private sector and involved in the training, in the first place, the decision makers at high levels and the people who give the money.
Partnerships across, whether it is decision makers, private sector.
For me, I would we need to demand constantly for safe, inclusive, and responsible use of AI. Don't stop demanding.
That's a very important point. The next week is all going to be about that.
It's hard because I feel like everyone has said what I want to say, but I would say focus on for private sector innovators, focus on innovation, not just for innovation's sake, I guess, but to actually solve solve a problem which people need.
Solve real problems, not just something fanciful.
Je dirais travailler à réduire les biais algorithmiques dans les données. Et donc, ce que fait aujourd'hui le Find ou Gavi et d'autres organismes, c'est super intéressant. Donc, essayons d'avoir des collaborations entre des startups et des structures comme le Find pour être vraiment présents sur le terrain et faire avancer les choses. Donc, partenariat et réduction de biais. Voilà, merci.
Okay, thank you.
Définir, avoir un cadre concret d'évaluation des différents outils qui existent pour être sûr qu'ils sont localisés, qu'ils sont pour les pays, pour les personnes pour qui c'est censé être utilisé, et qu'il n'y ait personne qui soit exclu dans le déploiement de ces outils, et donc construire des bases de données inclusives et représentatives pour pouvoir faire ces évaluations.
Thank you very much. I think that's... Yeah.
Je vais tricher, je vais rapidement passer en français. C'est très nécessaire pour cette exécution de placer l'emphase sur l'innovation et pas la novation. On a besoin d'innover pour faire quelque chose. Il faut que ça aboutisse à quelque chose. Point.
Okay, brilliant. Thank you very much. We are going to hold everybody accountable, but that's Dayo's job. Dayo, over to you. There's a picture that's going to be taken with everybody in the panel, I assume, unless... thank you.
Thank you, Pradeep and panelists, for holding our attention fully until 6:15. And thank you, audience, both those physically present and those attending online, for your patience and your continued interests. We certainly appreciate your energy and of course the rich exchange of ideas that we have had. Many thanks to all of our moderators, panelists, partners, and organizers for creating the space for this important conversation. Of course, I'm grateful for the partnership we have with the OEF, with Ambassador Perry Monsieur and the team. I think it's important to mention Natalie, who is not here, but worked very hard up to the time she went off. But thanks to all of the teams at Find, and of course, thanks to Patrick McGovern Foundation for co-sponsoring. I think in March, we had the Malaria Day event, which perhaps was one of the first times since I got here almost a year ago that we had all of us in the Global Health Campus participate in one event, and we've sort of pulled that off again today. I think the importance of the cross-fertilization of ideas and hopefully that will lead to well-informed joint actions for the benefits of the community we serve is hopefully going to be a concrete product from that interaction and collaboration across all of the entities in the Global Health Campus. There's not enough time to summarize what we've had, but we had 3 panels, and I think we had a lot about what AI can do and what it cannot do. But there's the issue of absolutely making sure that we do not allow AI to worsen the inequities that we currently have in health. And the way to do that, of course, is to have these kinds of conversations and to think about the relevant domains that need to be done. I think it's very clear from what we've had that we need to create AI solutions along with the communities that are meant to consume them and to serve in the service of their needs, not needs that we think they should have based on meetings in Geneva or in Washington or New York or elsewhere, but based on community needs. There's the, like everything else, there's the very important bit about governance and the various components as mentioned, so regulation, the ethics, and everything else in between. That's important. AI can be abused. There are deep fake videos. There's misinformation that we learned during COVID. A few years ago, I was in public office, and I basically there were images or videos of me going around touting cures for hypertension and diabetes. And I did not know until people started to write me emails to ask if they could get these magic cures. And my first response was, if I had those cures, I would probably quit my government job and retire early. But, so there is a part of misapplication and abuse that requires that we really pay attention from the word go to regulation and the ethics of use. We've heard about what needs to be done. We've talked about domains of data, domains of trust, and the like. And I think what I would just like to close with is, we've got to remember, because we're talking about health, that there's a system. And actually we need to, a lot has been said about moving away from thinking in silos, but to look at the system as a whole. If perhaps as part of health system strengthening, we're giving more attention to digitization of the health system, we will be better placed to adopt AI, to have the data to train models and the like. So I think it's important when we are now thinking about AI solutions to still keep an eye on what the big picture is and to see where AI fits, and end to end, as I think it was Sarah that mentioned, you don't always necessarily have to aim for the highest. There are low-hanging bits that need to be done now. And we can't, of course, make the excellent the enemy of the very good. The patient needs or healthcare needs that need to be sorted out, and we must always find better ways to solve them with the tools that already exist. So with that very poor summary, I'm paraphrasing and there's not enough time, I think it's my pleasure to bring this meeting to a close and to invite you to the reception. Thank you very much for all of your time, for the engagement we've had, and I look forward to, seeing you tomorrow, but also to re-echo the invitation from our ITU colleague about the whole AI for Good event that is holding next week. And there's that lovely report on the ITU website that we have been referred to that we should also download for essential reading. Thank you, and have a good bonsoir.